Hello. Welcome to a brand new medical surgical nursing lesson. My name is Jessie Wheatley, and I'll be facilitating this lesson. Please be sure that you have your notebook ready to take notes and you have your textbook available for reference. I encourage you to highlight any key points that remain unclear and to be sure to email me for any questions. This lesson introduces concepts in critical care nursing for respiratory patients. The topics that are going to be covered in this lesson include pulmonary embolism, acute respiratory failure, and chest trauma. It is important for the RN to remember that any respiratory problem can progress to a life-threatening emergency and death by interfering with oxygen and tissue perfusion and overwhelming the normal adaptive responses of the cardiac and blood oxygen delivery systems. RNs must have prompt recognition and interventions that are going to prevent some serious complications or death. By the end of this lesson, you should be able to understand that pulmonary embolism (PE) requires immediate identification by the RN and most often must be based on symptomology that the patient is exhibiting. It's important to discuss the management of anti-clotting therapy, including labs, monitoring for patients with PE, and to decrease further respiratory compromise. We are going to understand ERDS, acute respiratory distress syndrome, that it will require intubation and mechanical intervention, ventilation. We're going to review the goals of ventilator settings and strategies for weaning and removing intubation. A pulmonary embolism, a PE, is a collection of particulate matter, usually blood clots, that enter the venous circulation and lodges in the pulmonary vessels. PE is common, especially among hospitalized patients, and patients may die within an hour of onset of symptoms or before the diagnosis has even been suspected. If a large emboli that obstructs pulmonary blood flow, leading to reduced oxygenation of the body, pulmonary tissue hypoxia, and death, is pictured in this diagram here for us to review. Remember that diagnosis should be prompt and interventions should be prompt to decrease high mortality rates. Major risk factors for PEs are DVTs, embolism, prolonged immobility, central venous catheter presence, surgery, obesity, advancing age, increased blood clotting, a history of having a previous thromboembolism puts a patient at risk. Your textbook contains a chart that has the best practices for preventing DVTs. I would like for you to look at that. So what's going to happen after somebody has had a DVT? Typically, small doses of heparin may be prescribed to prevent excessive clotting in this patient after trauma or surgery prophylactically. This is really important. I have included in your chart best practices for PE for nursing care that I want you to make sure that you review. You want to immediately notify the doctor or a rapid response team for patients that are experiencing onset dyspnea and chest pain in you suspected PE. You want to prepare oxygen therapy for these patients immediately, and you want to also go ahead after they get there. They will probably want an ABG value. You want to continue to monitor this patient. Checking oxygen saturation by pulse oximetry. Any patient who's having trouble breathing or who develops acute confusion, you want to use aseptic technique when carrying these patients that require pulmonary suctioning. If they need suctioning, you will be suctioning them. Identify patients with your in your setting that are at risk for developing PE and monitor them closely. Drug therapy is going to be anticoagulants that may be prescribed. Remember, with anticoagulants, to use bleeding precautions for these patients. Heparins are most usually prescribed, and unless the patient is hemodynamically unstable or the PE is very, very large, fibrinolytics will be used instead. And fibrinolytics are like TPA may be used, but the patient should get a fibrinolytic must meet the criteria for treating a PE with a fibrinolytic. This criteria may be that if the PE is very massive and it impedes blood flow to a lobe of their lung more than one segment. If the patient is hemodynamically unstable and they can't keep their blood pressure without pressure support, they would probably go ahead and consider fibrinolytic. Okay, both heparin and fibrinolytic drugs are high alert drugs. The patient needs to meet criteria for fibrinolytic therapy if that's what's ordered. Okay, the drugs have a high risk to cause harm if given too large a dose or too small a dose or to the wrong patient. So you want to make sure that you know exactly how much you're giving and what the criteria for watching is. So you want to review baseline PTTs for this patient, and you want to review them. The textbook says every 4 hours, but per agency protocol. The PTT values are usually therapeutic when they are about 1.5 to 2.5 times above the baseline. Heparin therapy may be usually is prescribed the first 5 to 10 days with IV heparin therapy, and then the patients are switched to either oral anticoagulants or low molecular weight heparin. The oral anticoagulants may be introduced on day 3 of heparin therapy, and many agencies now are performing a genetic test before starting the Coumadin switching patients to oral anticoagulants. Well, your notes and your textbook go in detail about why these tests for genetic testing are being done, and I have included a page reference for you to look in your book so you can learn more. Okay, we do both heparin and Coumadin until the INR has picked up. It's between 2.0 to 3.0. A low molecular weight heparin may be started to continue with the Coumadin if depending on what the doctor has ordered. You want to make sure that as an RN you're keeping antidotes available for the patient receiving heparin or Coumadin, and you know what the antidotes are, and I've included those in your notes. Surgical management for this patient is going to be an embolectomy, a removal of a large emboli, or we're also going to do an inferior vena cava replacement to put a filter in. The notes includes a picture of what an inferior vena cava filter looks like. Another big important aspect of care is hypotension management. You want to check and monitor pulse and blood pressure. You want to check urine output. You want to check the chart skin color and turgor. You want to watch your IV fluids and know exactly how much is going in. You want to check your EKG. You want to check your pulmonary artery and venous right atrial pressures for patients to monitor for pulmonary hypertension. Drugs such as positive inotropics may be prescribed for this patient to make sure that they have optimal cardiac output. In your notes, I've included drugs to know. You will need to look at those. So you want to minimize bleeding. I've included what reference you need to use to learn the procedures of minimizing bleeding. You want to minimize anxiety. You want to know the discharge plan, and you want to know what the home care plan is as an RN. You want to teach these patients after their acute phase ways they can promote venous return and avoid having any more thromboembolic events, especially when traveling long distances. You want to make sure that they have O2 therapy in if they need it, and that it is humidified, and you want to make sure that the patient's positioned for comfort with their head elevated. Oxygen therapy is appropriate for any patient who has acute hypoxemia. Okay? Acute respiratory failure is classified by a PaO2 of less than 60, an arterial oxygen saturation of less than 90, or a PCO2 of greater than 50 occurring with a pH that's high. Acute respiratory failure is further defined as ventilatory failure, oxygenation failure, or a combination of both mechanisms. The patient in acute respiratory failure is always hypoxemic. Ventilatory failure is an issue with O2 intake that causes a ventilation perfusion mismatch in which perfusion is normal but ventilation is inadequate. Assess patients for dyspnea, which is a hallmark of respiratory failure. Assess patients in changes in respiratory rate or a pattern or lung sounds. You want to assess patients for manifestations of hypoxemia and hypercapnia. You want to notify the doctor immediately for any patient who develops a sudden onset respiratory difficulty. You want to check oxygen saturation by pulse oximetry for any patient who has trouble breathing and who develops acute confusion. Plan to evaluate the EPGs to assess the severity of this hypoxia. And I have included a reference with causes of ventilatory failure and oxygenation failure in your textbook. Acute respiratory distress syndrome, called ARDS, also shock lung, is an acute respiratory failure with hypoxemia even with 100% oxygen. There's decreased pulmonary compliance in this patient, dyspnea, bilateral pulmonary edema, and dense bilateral infiltrates on an X-ray. Causes are acute lung injury. Usually, trauma patients have a very high mortality rate from acute lung injury that leads to ARDS. Other causes are transfusion-related acute lung injury. This is pulmonary edema associated with activation of inflammatory responses due to transfusion reactions. Other causes are direct injury to the lung tissue or a serious nervous system injury, such as a head or a spinal trauma, strokes, tumors, increased cerebrospinal fluid. There is an increased risk factor with genetic. I've included a reference for you to understand that better in your notes. What are you supposed to do as an RN? As an RN, you want to assess patients at risk for ARDS. You want to make sure that you are watching patients and noting if there's any hyperapnea, grunting, respiration cyanosis, pallor, intercostal and subintestinal retractions, sweating, any changes in mental status in your patients. ARDS is diagnosed by a lowered PaO2 in widening alveolar oxygen gradient. Patients who aspirate acidic gastric contents are at great risk for developing ARDS, so you want to closely monitor these patients to feedings and those things that are in place. You want to make sure that you're watching these patients. Aspiration precautions with patients that have a low LOC, neurological checks, making sure that you're monitoring your patients that have an endotracheal tube in place very closely. You want to check the patients with ARDS hourly for oxygen saturation, vital sign changes, or any indication of increased work of breathing. Patients with ARDS will most often need mechanical ventilation. This will most likely be in an ICU setting. Corticosteroid therapy may be used to decrease the white blood cell movement and stabilize the capillary membrane. You need to be manually turning the patient every 2 hours to increase perfusion. And this has been actually proven to help, but most people say it's not being done as frequently as it should be. This patient is going to be on a ventilator and we need ventilator support. Let's review the patient requiring intubation and ventilation. Mechanical ventilation is usually temporary, but may be lifelong for those with severe restrictive lung disease, chronic progressive problem, or neuromuscular problems. But most often, it's going to be used for patients with hypoxemia and progressive alveolar hypoventilation with respiratory acidosis. This may also be used for patients with short-term after surgery who need ventilator support. How is mechanical ventilation achieved? The most common type of airway for short-term basis is the endotracheal tube. A tracheostomy may be recommended for a patient that needs artificial airway for longer than 10 to 14 days to make sure that we reduce tracheal and vocal cord damage from an ET tube. But if it's short term, they're going to put in an ET tube. The goals of intubation with an ET tube, there's a picture right there for you to look at, is to maintain a patent airway and to provide means to remove secretions and provide ventilation and oxygenation support for a patient who can't maintain a patent airway or remove their own secretions and ventilate and oxygenate. ET tubes are long PVC tubes, as you can see in this picture, pass through the mouth or nose into the trachea, most often in the mouth, but they can be passed through the nose. When properly in place, the tip is about 2 centimeters above the carina. Oral intubation is faster and easy way to go in an emergency, but nasal may be done if there's any facial or any oral trauma, or the surgery is going to be in orally. Intubation may not be nasal. Intubation may not be a good idea if patient has a blood clotting issue, but anesthesia takes care of that. And they also are going to be the ones that put the tubes in, anesthesia or pulmonologist. Tube placement, this radiopaque line that shows where shows up on X-ray to help demonstrate where the correct placement is, and depth markings. Okay. The nurse is responsible for helping to prepare to intubate. The nurse needs to know what her responsibilities are in this regard. Their job is to maintain a patent airway for anybody who needs intubation before intubation happens, also known as basic life support. So as a nurse, if a patient is going to require intubation, your duties just got increased. You want to maintain a patent airway with that patient. You want to manually resuscitate to deliver 100% oxygen with an ambu bag until that tube is going to be in. So your job is increased before that intubation happens. During the intubation, what are you doing? You're coordinating the response. You're monitoring vital signs, dysrhythmias, and aspiration. Each intubation attempt should not last more than 30 seconds. 15 seconds is optimal. After 30 seconds, somebody needs to manually bag the patient and resuscitate them to avoid hypoxia and cardiac arrest. After the patient is intubated, they will check the placement of the by checking the end-tidal CO2 levels or a chest X-ray. You want to assess the breath sounds. Make sure they have bilateral breath sounds. You want to check lung expansion. It needs to be symmetrical. That's what you're looking for to make sure that we did not end up in a right bronchus. Remember, we talked about that, but the intubator knows to do that. So the intubator will know to make sure that that happens, but you're also there to coordinate the response. If the tube is in the stomach, air is going to end up in there. They will probably need decompression with a nasogastric tube. The respiratory ther- the respiratory therapy, the RN or the anesthesia are work together to make sure that the tube that has been placed is stabilized at the mouth or at the ears. A bite block may be used to keep patient from biting the tube. I also have included a reference for you to learn more about intubation. Let's talk very briefly about mechanical ventilation. This is used in many settings, not just critical care. The RN coordinates and manages problems. I've included a reference in your notes for you to know what you need to know for a patient that's on mechanical ventilation. The purpose of mechanical ventilation is to improve gas exchange, to decrease the work of breathing, to support them as a supportive measure for a patient until adequate lung function returns or is maintained or until the acute episode of whatever is wrong with them has passed. A mechanical ventilation is not curative. You want to monitor continuously to see if the patient still meets the criteria for mechanical ventilation. There are different types of mechanical ventilators. The ventilator selection depends on the severity of the disease process and the length, the time that they're going to need the support. Okay, most mechanical ventilators are positive pressure ventilators. Patients need to have an ET tube or a trach in place to use a ventilator. That just makes sense. In your notes, I've included ventilator modes and a little bit more about understanding ventilators like pressure cycle ventilators and time cycle ventilators that you are more than welcome to read. When you're taking care of a patient on a ventilator, you want to make sure that you're addressing the patient's physical and psychosocial needs. You want to make sure that you are monitoring your priorities in caring for the ventilated patients, are monitoring, evaluating patients' response, managing the ventilator system safely in preventing complications. You're going to work very closely with the respiratory therapist in this regard. You want to use aseptic technique when caring for a patient requiring pulmonary suctioning. You want to make sure that you inspect the mouth and perform oral care every 2 hours for anyone who has an ET tube in, and that you're doing good. You want to make sure that all the system alarms are being addressed and the ventilator is functioning. Okay. The usual manifestations of ventilatory failure for a patient that's older may not manifest very early on, so you want to make sure that you relate the age-related changes as increased chest wall stiffness and the ones we talked about previously in assess lungs bilateral each hour for patients who are receiving PEEP. You want to teach the family ways to communicate with a ventilated patient. You want to allow family and patients the opportunity to express their feelings about what they feel about their patient being on a ventilator. Remember that the patients who are receiving mechanical ventilation are being chemically paralyzed. Usually they can hear and can feel. So it's important that you make sure that you're still taking care of the person. Okay. Weaning process is outlined in your book, and I also have included a reference in your notes. And also, extubation is the removal of an ET tube, and I have included notes on extubation as well, as far as the criteria you would need to know that. Chest injuries are responsible for about 25% of traumatic deaths each year. Few chest injuries require thoracotomy, since most can be treated with a basic resuscitation, intubation, and chest tube placement. The first emergency approach is going to be basic life support, ABCs, airway, breathing, and circulation, followed by a rapid assessment of the treatment and life-threatening conditions. You want to maintain a patent airway in all these patients experiencing trauma. Pulmonary contusion is a potential lethal life-threatening emergency that I've talked about in your notes, and also rib fractures. Understand frail chest, and there's a video that shows frail chest that I've included in the class. Pneumothorax, tension pneumothorax, hemothorax, and tracheobronchial trauma. You will need to make sure you review the videos that I've included with this lesson on these concepts. Thank you for listening into this lesson. I hope you enjoyed the lesson on pulmonary embolism, acute respiratory failure, and chest trauma. For questions about this lesson or any of the corresponding notes, please feel free to email me. Have a wonderful day.